Let's consider two patients. An 82-year-old woman who has never taken pain medication in her entire life, who has a bad knee and needs knee replacement surgery. And let's compare her to a 25-year-old young woman who has substance use disorder, who does heroin and has an alcohol abuse disorder as well, who just had a car accident and has broken her tibia and needs surgery on that. How do you think pain management is going to differ for these two patients? That's what we're going to be talking about today. Pain control. What do we use? When do we use it? Who do we use it for? And what different strategies do we use to control patients' pain before surgery, during surgery, and after surgery? We're going to be talking about tolerance to pain medications. We're going to be talking about peripheral nerve blocks, and maybe I'll touch a little bit on chronic pain issues as well. Okay, so let's start with this 82-year-old woman. She has a bad, let's say, right knee, and she needs a knee replacement with an orthopedic surgeon. And as I discussed before, she's never taken, a pain medication. And when I mean pain medication, for the moment, I'll say opiates. Now, opiates, there's many different types of opiates, right? There's a long record of opiate medication. So, like heroin is an opiate, right? Oxycodone. OxyContin is an opiate, but is the same thing as oxycodone. It's just extended release. There's methadone. There's hydromorphone, which is called Dilaudid in the United States. Morphine. Vicodin, hydrocodone. There's many different types of opiates, fentanyl. The list can go on. So let's say this woman has never taken opiates before. So the way I would address this, surgery is getting a knee replacement is painful, right? Obviously, you need to be anesthetized for the operation, and you need your pain to be controlled afterwards. Why do we need to control your pain? Obviously, it's like a human right. People shouldn't suffer. So we don't want people to suffer. Like, that's goal number one. Let's treat pain so people don't suffer. Pain gets in the way of rehabilitation. If someone is in pain with many different types of operations, whatever it is, it impedes your progress. You don't get out of bed. You're not active. You can have increased inflammation. Your stress levels go up. Your heart rate can be high. All of these things. Pain is bad. You don't want people to linger in pain. So in the world of anesthesia and surgery, we obviously treat pain. A knee surgery is a particular painful surgery. I mean, you literally have an orthopedic surgeon who fillets open your knee, moves the kneecap to the side, saws out your knee joint from the femur above and from the tibia below, and puts in a big hunkin' piece of metal in there with cement. There's hammers. There's all sorts of other equipment that I don't know because I'm not an orthopedic surgeon. And then they slap the whole thing back together again and send you on your way. That's going to be disruptive. That's going to be painful, obviously. So you need pain control for this. So for an operation like this, there's a couple things you could do. You could do a general anesthesia, send the patient off to sleep, put in a breathing tube. They're going to be asleep the whole time, and that will be how you keep them asleep. You can give them pain medications while they're under, and then I'll get into post-op pain. Or you can also do this under regional anesthesia rather than general anesthesia. Why is it called regional? Because we anesthetize a single region of your body, not your entire body. That's the difference. Remember that, regional anesthesia. What regional anesthesia means is a peripheral nerve block, a nerve block. We block that limb that you're going to have surgery on. We go in and we put numbing medication around a nerve and we block that. Now, you can get a nerve block either for what we call surgical anesthesia, so numb that you can't feel it even if you're wide awake, or we do it for surgical analgesia. Analgesia means pain control. So you either do it to completely block the limb so you don't feel it even if you're awake, or you do a peripheral nerve block for post-operative pain control. So there's different indications to do these things. Now for this 82-year-old who's getting a knee replacement, sure, you can do a general anesthesia, but there are benefits to doing a regional anesthesia, to doing a nerve block, numbing up that knee completely and having the patient just getting some moderate sedation. One of it is quicker recovery from anesthesia. The older we get, the longer it takes to recover from general anesthesia when you're totally deep. So if you're at like 82, it can take a long time. It can take hours to recover from general anesthesia. You can also have delirium and confusion and cognitive decline from general anesthesia as an older individual that can last days to weeks to months and can be permanent. So That right there is a reason to avoid a general anesthesia. And then this patient could have other comorbidities that might make a general anesthetic unsafe, like heart failure or bad COPD, where if we put a breathing tube in, we could cause like bronchospasm and have difficulty ventilating. Anyway, there's many comorbidities that might make this an ideal scenario. So for this patient, we could do a spinal anesthetic, which we deliver a very small amount of numbing medication, usually something called bupivacaine, into the spinal fluid, which directly anesthetizes and numbs the spinal nerves, which would cause a very dense block, below the waist, depending on how we do the spinal block. And that would give you surgical anesthesia, so the patient wouldn't feel anything. And then you can sedate the patient with like a propofol infusion that goes through their hand or some other sedative, where they're kind of in and out of conscious sedation, kind of like a colonoscopy or something like that. And then you could also do a peripheral nerve block for post-op analgesia. We could do a nerve block lower in the leg, and this can all be done preoperatively. We do a nerve block. We can do for something like that, you could do a femoral nerve block where with ultrasound, we look at the femoral nerve kind of below the groin. We identify it next to the vessels. We watch our needle as it goes in, and we infiltrate local anesthetic around the nerve. And then however, a femoral nerve block might limit the patient from getting up and walking around because it can really deaden their leg. So you could do a different type of nerve block of the leg. You could do a popliteal and an adductor canal block. My point is, we don't need to get into the weeds too much. There are many different options with peripheral nerve blocks, and it's all customizable to the surgery and the patient. You could do a surgery like this with these nerve blocks, and this patient could do this opiate-free, the entire operation, and even the post-op recovery opiate-free by doing this. Now, it doesn't mean that patient can't have access to opiates like fentanyl or hydromorphone or something like that. But there are ways of doing things where you can be opiate-free. And when we say opiate-sparing, that's what we mean. There are benefits to being opiate-sparing. And I know it's very controversial and it's been in the news a lot. The pendulum has swung the other way, right? So doctors in the 90s and into the 2000s, we have caused, not just doctors, but pharmaceutical companies and corporate self-interest, has caused opiate epidemic. I mean, that for sure, right? Particularly with the drug OxyContin. So the pendulum is swinging back the other way, where doctors and hospitals are being restrictive with their opiates. Now, it's a good thing that we're being more restrictive, okay? But before we jump to conclusions, let me qualify that. It's a good thing because we were overprescribing and patients were being killed, and causing addictive behavior. That was happening, and that was a problem, clearly. So it's good that we're being more restrictive and opiate sparing. Now, that doesn't mean that patients shouldn't have good pain control. And opiates are still a part of intraoperative and postoperative pain, particularly with acute surgery. And if anyone argues otherwise, that, we should just do Tylenol or Toradol or ibuprofen or something like that, I don't agree with that. Opiates should be used. They should be used. And they should be used postoperatively. To not prescribe a patient 0 opiates after their surgery, you just send them home, say take Tylenol and ibuprofen, I don't think that's appropriate either. It might be for some surgeries, and it might be for some patients. Maybe some patients are like, no, I'm fine. And they are, and they do fine. It needs to be customizable. Now, back in the 90s and 2000s, should we prescribe 30 days of opiates for a surgery? Absolutely not. That was way too many opiates. The reason that was way too many opiates is, number one, if you get a fry from McDonald's, if you say they have a large fry, and you buy a large fry and you eat a large fry, and then the next week they come out with supersized or whatever. I don't know. I don't go to McDonald's often, and now they have a larger size, and you get that. You will eat all of those fries just because they're available. It's a similar concept. If you have a 30-day of opiate prescription, someone might just take all of that, not because they're a drug fiend or whatever. Sorry to use that phrase, but they might take them just because they're available, and then they might not take them. And then they sit in the house, and then a teenage child can then take them and abuse them or sell them, or someone can. So, I mean, it's obvious why that's a problem. But having a short course, a few days, 5 days, 7 days, depending on the situation, of opiates after surgery, in my opinion, is completely, it's very appropriate still. Okay, let's move to our next patient, the 25-year-old young woman who is addicted to heroin, who has substance use disorder, and she also has alcohol use disorder and uses heavy alcohol. She gets in a car accident and she breaks her tibia, which is the bone below your knee. And she needs surgery, fairly soon here. And so someone like this is a completely different scenario, right, than our 82-year-old woman. So this the 25-year-old woman has had opiates in her system for a long time. Maybe let's say she's had years of addiction. What happens with tolerance? It's all about the little receptors in your cells. So the way pharmacology and biochemistry and cellular biology, all that works is every cells have receptors on them, proteins that are on the outside of the cell, and things come up and they lock in with that, whether it's a drug or a hormone or something, and they will interact with that receptor on that cell, and it'll make the cell do something. That's just kind of a basic cellular biology. So opiates interact with the mu receptor, the mu receptor, which cause all the and there's mu receptors in all different tissues and all different types of your body. Now, depending on the type of tissue and the type of cell, the receptors have different. The receptors can cause different effects, right? So let's say you have mu receptors like in your spinal cord. So when opiates get to your spinal cord or those nerves, it is what gives you pain relief in nerves when the mu receptors are stimulated by opiates. It's how you get pain relief. It's also why you may experience euphoria. Now, there's also mu receptors in the cells in your gut. And what happens when opiates interact with those mu receptors? It decreases gut motility. What that means is you get constipated. Okay. Well, so what about the other mu receptors? Well, there are nerves that are responsible for you to breathe, that are responsible to make your diaphragm go up and down. Well, when the mu receptors interacts with those, it makes those nerves not fire as often, and so you get respiratory depression. You stop breathing, and that's why opiates are deadly. They make people stop breathing. That is the reason. So if someone overdoses on opiates, it's because they stop breathing. It makes your body not care about breathing until you stop breathing, and that's often how people can pass away from opiates. Okay, so what happens when so these receptors are there, and every cell has a certain number of receptors. Let's say a particular cell has 10 receptors. They obviously have more than that. Okay, so there's receptors, and now you're sending opiates after those receptors, and they cling to those receptors. Well, by stimulating those receptors, you also change the way those receptors. That's how that cell behaves. That's making those receptors. The cell makes the receptors and sends them up to the cell membrane. And this is a key principle. If you stimulate those receptors over and over and over again, you down-regulate the synthesis of those receptors. Let me repeat that. If you stimulate the receptors over and over again, like the mu receptor with opiates, you will down-regulate the receptors. So now instead of having 10 receptors, if you are flooding those receptors, the cell is like, oh, this is too much stimulation. I am going to down-regulate it, and it stops making receptors. So maybe it only puts out 5. And then you keep hammering them over and over again, and so it only puts out 1 receptor. So what is the significance of that? So that's called down-regulation of receptors. The significance of it is if someone still wants to have the same euphoria from opiates, right? And they take them every day, you get down receptor of the receptor. So you need more and more and more of opiates to get the same sensation, and get the same physiological response, which in this case is euphoria. So you need more and more and more. That is what tolerance is. And this is a key concept, right? So this is why our 25-year-old young woman in this state, I could come along and I could give her maybe 10 milligrams of hydromorphone IV, which is a lot. That is a lot. If I gave that to the 82-year-old woman, it would kill her. She would stop breathing and she would die. But perhaps if I gave it to this 25-year-old woman, maybe it wouldn't even touch her pain. Maybe she wouldn't even feel it. By the way, I would never give 10 milligrams of IV hydromorphone to anybody for any reason. That's way too high to start out. But my point is, I have seen patients many, many, many times that are addicted to heroin or addicted to opiates. It doesn't have to be heroin. It can be, something that doesn't have so much stigma. People can be addicted to opiates and not appear that they're addicted. Anyway, my point is, I've seen people where the amount of opiates that they're getting in one day would kill 10 people easily. It would kill 20 people. I've seen a hospital supply, the pharmacy at a hospital, their supply of Dilaudid be drained because of one patient that day. And I'm not joking. That's not an exaggeration. This is literal. They ran out that day and they need to order more because one patient completely drained the supply. Tolerance has no bounds. You just keep getting more and more tolerant. And it doesn't cause respiratory depression because those same receptors that cause respiratory depression with opiates, they get downregulated as well, so they don't get as stimulated. What I'm describing is a huge reason why people that do have substance use disorder, why they accidentally overdose. So someone who is addicted to opiates, they go into detox and rehab and they get completely off of them. And then they're back out in the community and they're not in a rehab facility center or whatever it is. And then they relapse. And they take these same, and without thinking, they take the same dose of an opiate that their body was used to months ago or weeks ago, and they take that, but now all their receptors have upregulated. And now they take that dose that they thought was going to give them their original high, and it kills them. That's why people die after relapse when they take the same dose. All right, so let's go back to our 25-year-old patient. So she's going to be screaming in pain, I guarantee you, because she is hyperalgesic. Remember that word analgesic? Analgesic means, to control pain. Hyperalgesic means you experience pain in a different way. So not only is this patient tolerant, the way she experiences pain is different than someone who is not addicted to opiates. It's different. They have a different experience. Their pain is exaggerated. And then they're probably not getting enough opiates, pain control. So someone is coming along and just giving them a little bit of pain control, and it's just like water doesn't touch them because they have tolerance. So not only are they tolerant, but they're hyperalgesic. So if I saw this young woman, I guarantee she would probably be screaming in pain. And for one thing, she needs a lot of opiates before she even has surgery. She should be loaded up with them, because she shouldn't be, for one thing, she shouldn't be suffering just because she's addicted. She has substance use disorder. Doesn't mean she should suffer. We can still control her pain, even though it takes more. And it's a human right, in my opinion. She needs that pain control. She should have whatever she needs to get control of her pain before she goes back for surgery. Now, when considering the anesthetic for this surgery, so this is an ideal candidate for a peripheral nerve block, just like we were talking about. Why? Because this patient is tolerant to opiates and she's hyperalgesic. But she's not tolerant to local anesthetic, right? With the nerve block. So we can go in and numb that leg with local anesthetic around the nerve. She doesn't have any more tolerant to that than our 82-year-old woman. So we can just put a peripheral nerve block in. We leave a little catheter behind that sits right at that nerve, and we give it continuous infusion, and that can run through the surgery and after the surgery, and it can help control her pain. Now, she may still have breakthrough pain and may still need good pain control with opiates or things like that. But this is an ideal candidate for peripheral nerve block. She is also an ideal candidate for other classes of pain control, medications for pain control. She should get Tylenol. Okay, she should get 1,000 milligrams of Tylenol right up front. And she should get ketamine. I would absolutely load this patient up with ketamine. So when people have substance use disorder and they use opiates, ketamine is its own class. It's called an NMDA antagonist. It hits different receptors. It's completely different than opiates. And it can be very, very effective in patients like this. So if I met this patient the first time I was her anesthesiologist and taking her back, I would load her up with opiates. I would give her a ton of ketamine, all IV. I would even give her a benzo because she could be super nervous and super anxious. And she's being monitored. We'd monitor for respiratory depression because there's another concept called, they're synergetic. Like benzos, which is like midazolam or Ativan, are synergetic with opiates, and they can both together cause respiratory depression. That can be very dangerous. But I would give those things for a patient like this, and, assuming she's closely monitored, to get her comfortable, to get her to trust her care team, and to get her through the operation, and to prepare her for it. Now, when approaching the actual anesthesia for this, so you could do a nerve block, and then sedate her with something like propofol. But that nerve block's got to work really well. It's possible all of this stuff may not be enough, and she may be so so tolerant and so hyperalgesic that while the surgeon's trying to do surgery, the patient is feeling it, and then we would have to send her off to sleep. So depending on the situation, it's not unreasonable to send this patient off to sleep with a breathing tube as well, with a peripheral nerve block as well for post-op pain. And now for this young woman, she needs very, very close post-op pain control. She needs a dedicated team of pain specialists, which are anesthesiologists, right? It could be someone like me, an anesthesiologist, or it could be an anesthesiologist who's done an extra fellowship in pain management, which ideally it would be. But not all hospitals have that luxury of having someone that's extra trained. I did not do a pain fellowship. So, but a dedicated team of pain specialists should be managing this young woman's pain. for her peripheral nerve block. Maybe she needs a ketamine drip, and then to very carefully give her the right amount of opiates. Now, there's something called a PCA, patient-controlled analgesia. Remember the word analgesia. It's patient-controlled. It's the button. I don't know if y'all have had that when you're in the hospital. It's a pain button. They press a button, and it gives you a injection of a pain medication, usually hydromorphone, sometimes fentanyl, which I'm not a fan of, or sometimes morphine. I'm also not a fan of morphine. And that's called a PCA. So in case you're wondering, it's not a placebo effect. We're not just giving you saline for one thing that's dishonest. We can't do that. That's unethical. You are getting the pain medication. However, not every time you press the button, it doesn't mean you're getting the pain medication. There's a lockout. And it's extremely safe, these pain buttons. They're very safe to use. So what I mean by a lockout is, okay, we can set it. It's like a pump. It's on a little pump computer. And we set it. We'd be like, okay, every time the patient presses the thing, they can get, like, let's say 0.4 milligrams of hydromorphone, which is also called Dilaudid, and it gives them that injection through their IV. But then it's a lockout. The computer will be like, okay, the next time they can get it is in 10 minutes. So if the patient presses the button 5 minutes later, they won't get a push of the medication. And you tell them, hey, press this whenever you have pain. That's what I tell patients. Just press it whenever you have pain. I'll tell them that there's a lockout if they want to know that also. But we can decrease that interval. We can decrease it to 8 minutes or 5 minutes. It just depends on what's going on. And you need anesthesiologists to do this because this can be dangerous. But the beautiful thing about a PCA, patient-controlled analgesia, the button, is that it's safe. So the patient presses it, and if they get over-sedated from medication, they'll fall asleep and they'll stop pressing their button. So it's a safety mechanism that's in place. And I would definitely give this patient, this young woman, I would give her the peripheral nerve block, I would give her a PCA, and I would put her on a ketamine infusion at a baseline. I would also have maxed Tylenol scheduled around the clock and also Toradol, which is a great medication. Now, having done all this patient will likely still be in pain. In fact, if I were to ask her, what's your pain? All these stuff she's already on. If I were to ask her postoperatively, from 1 to 10, what's your pain? She would probably say a 10 out of 10, maybe even a 9 out of 10. And she could even say it very calmly. Is she lying? No. That's the pain that she's experiencing. It is virtually impossible to take away the experience of pain from patients like this. It's debatable, but it's like impossible. And I believe them. They are experiencing that pain. Are they also drug seeking and wanting more? Probably, right? They probably are. They also want to feel they want to feel normal. What their normal is having their body saturated with opiates. So the behavior is complex, right? They are in pain, and they also can be drug seeking. And it doesn't matter. We don't need to tease these things apart as providers. We're not going to, particularly in this setting, we're not going to fix their addiction. Now, we need to make sure that we set them up with good chemical dependency programs, and even set them up with a methadone clinic afterwards, which we can do, and some hospitals do have those resources, and all should. And that is our duty, right? For a patient like this, this is a good time, to help a patient not only get through their surgery, but to help them maybe even, arrive at the point where they want addiction recovery. And they need those resources as they approach discharge from the hospital. And if we don't give them those resources, that's an enormous, enormous disservice to a patient like that. Now, they can't be coerced into starting a methadone program or anything like that. And patients will decline. They'll be like, no, I'm not going to do that. And they leave. And that's fine. That's their choice. But many patients do, take us up on those offers when we offer those resources to them. Now, I want to be clear that I do say no to patients. I'm not, I don't just pass out opiates and benzos because I want to be a nice guy to patients. There's a point where, take the 25-year-old woman that we're talking about, where I would absolutely say no to her. But those conversations, they take a while, and they need to be nuanced. They need to be felt heard. They need to be heard, and they need to be felt heard. But you have to toe a line, because someone who has substance use disorder, from my experience, they typically are never satisfied with the opiates that they're getting, ever. And maybe I shouldn't say that across the board, but from my experience, they're never satisfied with they always want more. So you must be with patients like that. It's important to be firm that, look, I'm worried, because what can happen is you need more and more because you're tolerant, but the more you give, your respiratory drive can still go down. They can still suddenly die. I mean, these patients, they can be wide awake saying they're 10 out of 10 pain, and then you turn around, you leave the room, and they fall asleep, and the respiratory drive is completely taken away, and they die. That can happen. That can absolutely happen to patients like this. So these things need to be explained to them, and of course they logically can understand these things, but they viscerally, typically, always want more, and they oftentimes have an insatiable appetite for more opiates. So there are times when you must give pain medication to help treat, and there's times when you have to stop. And this is why context is so extremely important. I'm seeing this kind of more of a social movement that's kind of this revolt against doctors and providers trying to be opiate sparing. It's a wise thing to try to be opiate sparing. Opiates are extremely powerful, extremely dangerous medications, synthetic opiates, right? The human body does not produce its own synthetic, opiates like this. The human body does produce opiates. They're called enkephalins, but what we produce are, astronomically more potent. So context matters. Context is everything. If you see a headline you hear in the news, like Dr. Husel, he gave 2,000 micrograms of fentanyl. This is if you're not familiar, he was the critical care doctor who gave outrageous amounts of medications to patients as they were dying to help them as they die, which is a routine practice. But he gave medications that were in extremely high doses, way outside of the practice. And it's easy to say those doses were too high. What you can't say is that those killed the patients and he's a murderer. You can't say those things. You must understand the context. You have to look at every single one of those patient cases. You have to know what their tolerance level was. They could have been on a lot of opiates already because they were critically ill. And those two things correlate very strongly. So you must understand context because of tolerance. People are at different tolerant levels. Now, when it comes to chronic pain patients, outpatients, so let's leave those two other patient scenarios behind. Now we're talking about chronic outpatient pain. Now, I am not a chronic pain doctor, and I'm not technically a pain specialist. And let me back that up. I think all anesthesiologists are pain specialists, but a real pain specialist is someone who's done an extra fellowship in pain. And several different types of physicians can do fellowships in pain. Anesthesiologists, that's very typical. Neurologists can do it, and so can psychiatrists. I believe another specialty that I'm not remembering off the top of my head. But these specialties can do extra fellowships and specialize in pain. Patients for chronic pain. This is a completely different type of patient population. Someone who has chronic back pain, or they've had a traumatic injury to a limb, and now they have chronic pain for decades because of that. So this is a whole different ballgame than the prior patients that I've just been talking about. For these types of patients for chronic pain, many are opiate dependent. A lot of people need some sort of low-level opiate to even get out of bed, to even function. And if that's what they need, then that's appropriate. As I said before, opiates have diminishing returns. You experience tolerance. And so what can happen, you can get in the same scenario where someone who has chronic pain is on an opiate, they constantly need more and more and more, and then they get in this they can get in a problem where now they have substance abuse because they're constantly needing more. So that is something that needs to be avoided. So for chronic pain patients, we use something called multimodal analgesia. Multimodal, different pharmacological methods. So there's a lot of different medications out there that are non-opiate. And they get a bad rap by chronic pain patients because they say, well, they don't work. So there's things like, and I get that experience, and maybe they don't work for that patient, but something may work for someone else. And when you have chronic pain, even just a little bit of relief in some way can help things. So many different medications like gabapentin, amitriptyline. There's a whole host of medications, mirtazapine, tizanidine, that are used in a multimodal approach. One of the other things that's used can be like steroid injections in the spine, a spinal cord stimulator. There's a lot of other procedures that pain physicians do, that they perform, that can help with chronic pain. And I will repeat what I've said in my TikTok and here in this podcast, that it is best to be as opiate sparing as possible. That doesn't mean opiate free. That doesn't mean you should never have opiates, but it is not, being dependent on opiates is not typically a sustainable way of doing things. Now, having said that, I'm not someone that's had chronic pain, so I don't understand that experience. So if you're listening to this and you're a chronic pain sufferer, and you're taking offense at what I say, I get it. I don't know if I get it, but I don't have a problem with you maybe having an issue with what I'm saying. And I would love to hear more. And I'm totally open to being challenged on the things I'm saying. And of course, let me just say again, I'm not a chronic pain specialist. So I'm talking a little bit outside my field. So I'll give you that waiver for whatever it's worth. All right, let's switch gears. I want to talk about a book. And usually I try to make some sort of clever segue from what I'm talking about with healthcare into the book and social issues, but I'm just not that clever enough. So this has absolutely nothing to do with a prior conversation about pain. So just bear with me. So this book, I don't think I've actually talked about on my TikTok channel. It's called Kill Switch: The Rise of the Modern Senate and the Crippling of the American Democracy. It's by Adam Jentleson, Jentleson. Kill Switch. That's the name of the title of the book. So this book is about the filibuster, and it's released pretty recently. I'm just looking up here, January 2021. This book is very good. So if you're like a little bit demystified about the filibuster and its significance, this book is for you. So basically, just kind of giving my analysis of the book. In a sentence, this book, the filibuster needs to go. It needs to go. I was hesitant to dive into this book. I was afraid it was kind of just a liberal rant, offering just like sensationalism. And certainly there is liberal bias by the author. But I was pretty happy to find a lot of history about how the U.S. Senate has become this obstructive, rusty, old, calcified, corrupt body of a minority will that it is today. The author lays out some important groundwork, starting with James Madison. Madison's often quoted by those who assert that being a republic is supposed to protect the minority from the tyranny of the majority, right? You hear that a lot. This is a modern conservative spin, and Madison, in fact, intended the exact opposite. A republic, by design, is supposed to be ruled by a majority consensus, not a minority. The Senate was designed from the beginning to legislate by simple majority, meaning a simple 51 out of the 100 senators. Is it perfect? Is that a perfect, system? Of course it's not. But we weren't supposed to have a system where senators that literally only represent 35% of the population can obstruct policy when the majority of the public clearly favors it, which is the situation that American public finds itself in right now. The current filibuster is new, and it's not what was originally intended. The author lays out some nice history. One in particular, he gives a lot of history about John Calhoun. He was a white supremacist, segregationist senator. He was vice president from South Carolina as well. He very much tried to get minority will to drive everything that the Senate did. He's basically the grandfather of the modern filibuster. Unlimited debate was not intended by the framers of the U.S. Constitution, but that's exactly what Calhoun wanted, to obfuscate, to protect Southern white supremacy and their economy of slavery. Filibustering started to be used when something called Rule 22, and that was something I didn't know about, was invented as a slavery abolition obstructionist tool and to continue to ensure power of the Southern states. Whether it was Democrats or Republicans at the time, either way, it was used by Southern white supremacists to preserve a white apartheid state, right? Because doesn't matter, it's been Democrats or Republicans throughout history. They both have used this and they both have represented the South. And then you flash forward to LBJ and Jesse Helm. These two men greatly contributed to what would become the modern use of the filibuster today. The superminority draws its strength from conflict, not from trying to obtain broad appeal. These senators figured out that as long as they don't anger their base, they can become political heroes simply by filibustering and to require a supermajority to even vote on bills. This is why it's so important for them to keep stoking culture wars so that their base agrees with what they're doing. But requiring a supermajority does not encourage debate and consensus. It only obstructs and creates false political martyrs who, as I said, continue to stoke culture wars and bring in campaign dollars. Harry Reid was also radically changed filibustering when he went nuclear. I don't know if you remember that. And made it so that presidential appointments didn't have to have a supermajority, except for Supreme Court appointments. And then enter Mitch McConnell, who ironically earlier in his career was an enormous voice for campaign finance reform, which is laughable. McConnell then tried to get corruption defined as only explicit exchange and quid pro quo. This was obviously before Citizens United ruling, which made all this moot and which basically destroyed U.S. elections, in my opinion. Anyway, I found Kill Switch to be hugely informative, and it brought to my mind the big problems with our Senate. The foremost is that the filibuster is abused to require a supermajority. The facts are simple. A minority voting bloc of white Americans wield outsized control over the U.S. through the Senate. 35% of the U.S. population controls the levers of meaningful legislation. And this is a new trend. Before Obama, there was only 82 filibusters ever. During his administration, he alone had 86 filibusters by the GOP. This is unprecedented stuff. The bottom line is the filibuster is anti-democratic, it's corrupt, and it must go. It could happen too, but there's not enough political will, and there's too much corruption. All right, let's get to questions. I at the end of the podcast, I'd just like to answer a couple of questions from TikTok and my Gmail that I can't always do video replies to. So here's a question from this is from TikTok user Lucky Lou Coco 2. How do you feel about assisted suicide? In Canada, I've had 2 relatives use it, both cancer patients. So what they're referring to is assisted suicide. In the U.S., we also can call it death with dignity, which some U.S. states have. What this is someone has a terminal diagnosis that they are not going to survive. It's 100% that the prognosis is terminal, meaning they will die. A physician or a provider can prescribe enough sedative medications that it will kill them. So from what I understand with death with dignity laws, it's in those states it's legal to prescribe the medications with those intent, but only the patient themselves can take that medication. Only themselves can administer it, and if they don't, and if someone else administers it to them, then it is murder. I know there was a case I think in Oregon where there was a woman who was terminal, and her husband administered the medications to her, and he went on trial for murder. Anyway, how do I feel about it? I support this death with dignity, and it's such a great term, death with dignity. It describes what it is. People should, if you have a terminal diagnosis, I believe you should decide the time that you would like to pass away, because it's all about quality of the time that you have and not maximizing the quantity of time that you have left, in my opinion. So if someone decides that they feel like they're at the end of their life and they don't want to continue, and they don't want to experience the dying process, and they don't want to expose that trauma to their family as well, and they can pick a day that they decide to say goodbye, and they take the medications and they pass away peacefully and painlessly. So I do support this. Now, this is not euthanasia by my definition, how I think of it. Someone may differ in that opinion, that it's encouraging suicide. And I understand that this is a moral quandary, and I don't discredit those that may have a problem with this. I do get this, the sanctity of life needs to be preserved and protected. But I am in support of death with dignity laws. I think it's a humane way of doing things. All right, let's do another question. This is also from TikTok. This is from user, let me see. LadyLift8909. This person asks, they have a herniated disc. Can I safely use Motrin and Tylenol together? So, to be clear, Motrin is ibuprofen. It's a different brand name for ibuprofen. Advil is also ibuprofen. It's the same generic. So the generic name is ibuprofen. That's what I'll refer to it. Tylenol is acetaminophen. Can you use both of them safely together? Absolutely, you can. And if you have pain and chronic pain, I think a person should use both of them together. People usually don't think ibuprofen, which is an anti-inflammatory, works that well, or Tylenol doesn't work that well. And from my experience, it's typically because they do not use enough. They do not use enough of prescribed medication. Now, in the hospital, we typically use 1,000 milligrams of Tylenol, acetaminophen, every 6 hours. That's the maximum dose. You can't go more than that. And ibuprofen, 600 milligrams every 6 hours. And you can give them together. You can also stagger them. Now, don't take this as medical advice. I don't want you to take those doses of medications just based on what I am saying. You must talk to your doctor, because you shouldn't take that much Tylenol. Maybe if you have liver problems, then you shouldn't take that much ibuprofen if you have kidney problems or if you're a little older. So please do not take those doses based on what I am saying. This is not medical advice. But those are typical doses that we'll use in patients that are otherwise healthy And it's actually pretty good pain control if you're doing that round the clock. So yes, the answer is 100% yes, you can do both of these medications together. But you have to be careful that you're not doing too much of either one of them. But they can definitely be given at the same time. All right, that'll wrap it up for this episode. Please email me at icudrecmo@gmail.com. That's icudrecmo, ECMO @gmail.com. If you have any questions or if you have any suggestions about what to do for this podcast, you can check out my TikTok content at my handle is ICU Doctor. And then I'm on Instagram, ICU Doctor TikTok. And so, yeah, just reach out, give me suggestions, give me questions, whatever you like. Thank you for listening. If you've listened to the end here, I do appreciate it. Let me know things you like about the podcast. And then please rate and leave a review and share it with other people. Thank you.